Leuko stands for white and plakia for patch. Leukoplakia, classified as potentially malignant disorder, is a white patch that cannot be rubbed off and cannot be clinically diagnosed as any other disease. It has had numerous definitions over the years since it was first defined. In 2005, World Health Organization defined leukoplakia as a white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. The definition of leukoplakia is unusual in that the diagnosis is one of exclusion of other white lesions rather than depending on a definable appearance of the lesion. To make it easier to understand, let's say you have a patient with a suspicious white patch in the buccal mucosa. Since there are several other white lesions that look like leukoplakia, make sure it is not any other white lesion. Only after this could you make a diagnosis of leukoplakia. Hence, it is a diagnosis of exclusion. Leukoplakia, or any other white lesion for that matter, appear white because of the thickened surface keratin layer in the hypoplastic epithelium. This thickened abnormal keratin layer evenly reflects the visible light spectrum, as opposed to being permeable to visible light and the red spectrum being reflected by the connective tissue. This clinically masks the vascularity and the redness of the underlying connective tissue, making it appear white. Most cases of leukoplakia are related to the use of smoked or smokeless form of tobacco and may or may not regress on discontinuation of the habits. Other factors like alcohol, trauma, and Candida albicans have also been reported to cause leukoplakia, although these associations are now being disputed. Leukoplakia with no known etiological cause has been termed idiopathic leukoplakia. This lesion is the most common precancer and usually affects the middle-aged and the older population, with majority of the patients older than 40 years. Worldwide prevalence of leukoplakia is believed to be around 2% and it increases with age. It was known to have a higher male predilection but is now seeing a shift with a nearly equal number of women being affected. Buccal mucosa, mandibular vestibule, gingiva, and the lateral borders of the tongue are the most commonly affected sites. Other locations, though rare, include the lip, the floor of the mouth, the retromolar trigone, palate, mandibular, and the maxillary alveolar ridges. Leukoplakia is classified as being homogeneous and non-homogeneous. Homogeneous refers to the uniformity of the color and the texture of the leukoplakic lesion, while non-homogeneous leukoplakia may have a red-white appearance or may have a uniform white appearance with an irregular texture manifesting with nodules, wart-like projections, and corrugations. Homogeneous leukoplakia in the early stages may be thin, flat, or slightly elevated gray-white in color with fissures, while the leukoplakia that has progressed could be a thicker white plaque with deep fissures. These lesions are well circumscribed with sharply demarcated borders. Now, if these homogeneous lesions develop surface irregularities, they are called granular or nodular leukoplakias. And they are called verrucous leukoplakias when they develop deep corrugations and wart-like projections. Leukoplakia may reveal red patches manifesting as a mixed red-white lesion called the erythroleukoplakia or speckled leukoplakia. A notable form of leukoplakia called the proliferative verrucous leukoplakia appears in multiple sites, showing slow, persistent growth, eventually becoming verrucous and exophytic with a high rate of recurrence even after treatment. The prognosis of leukoplakia depends on various factors and is generally considered bad if it manifests in males, if the lesion is present for a long duration, if the affected is a non-smoker, if the leukoplakia is located on the tongue or the floor of the mouth, if the size is greater than 2 centimeters, and if the lesion is non-homogeneous. In the absence of dysplasia, excision is not mandatory, although the patient should be under continuous surveillance and evaluation every 6 months. Rebiopsy of suspicious areas should be done whenever necessary. The use of antioxidant nutrients like vitamin A, C, and E, beta-carotene, and a diet high in antioxidants like fruits and vegetables are recommended. Leukoplakia with mild dysplasia is managed according to its size and response to conservative measures like habit cessation. For moderate to severe dysplasias, excision should be done if feasible. although there are several studies which report that surgical excision do not reduce the risk of recurrence or the patient developing carcinoma. Grafting procedures may be necessary after large excisions.